Hi everyone. Sorry we're a couple of minutes late. We were just gathering together and also waiting for this. Someone has decided to start drilling at 5 to 1 outside the office. So if you hear some drilling noises in the background, I apologise. We were hoping it would finish, but they seem to be very intent on that. Anyway, welcome to our third monthly town hall. Just a very quick bit of housekeeping to start with, really. So as always, this is live at the moment. We're going to have a recorded version if people can't join us at the moment. But it's always good if anyone's there with you who can join us live. It would be great if they could, and it just means they can also kind of participate in the discussion. We're going to be monitoring the Q&A. I think, let's see if there's anything actually in there at the moment. Yes, there is some, and Bex is telling me that it's quite echoey. I think it could be because of this drilling, but hopefully it gets better. Yeah, so you can ask your questions using the Q&A function, and we'll either answer them in private, or we might publish them for everyone if we think they're useful for everyone to see. And yeah, as always, very keen to hear what you guys want us to talk about. This month, again, we've come up with a nice little agenda that hopefully should take us through for an hour. But that we will see how we get on, and if there's anything that people do want to cover, they can obviously put it in the Q&A now, or we can cover it next time. Great. Okay, so we're going to get started. I think we've got a few people joining us, so it should be okay. So the agenda today is really quite similar to last time. We're going to cover one kind of bigger topic, which this time is about targets, KPIs, QOF, and then we're going to go into update on flu, update on COVID, something a bit more fun, so Christmas and the Penrose Cup, which hopefully you guys have seen a poster of that went up the other day. Then we'll probably just have a little bit of a general update, and then we'll just talk about next town hall dates. So that's it. We'll try and kind of keep it to an hour, if not less, so hopefully you can stay with us. Great. So the first section is going to be presented by Greg. So Greg is going to take us through. Greg's done a lot of really hard work on understanding our targets and our KPIs for this year. Obviously, a lot's changed because of COVID, and so we want to make sure we know where we are and we know what we've got to do. And so Greg is going to take us through that. If I can figure out how to add him to the, yeah, here we go. Greg, take it away.
Hi everyone, hopefully you can hear me. Do you want to just mute yours, Serge?
Yeah.
Thank you. So the aim from this little conversation is just to go over the targets and KPIs we have for 2021. As Sachin said, a lot has changed. Because of COVID, they understand that primary care is a bit more limited, and reprioritization has definitely been done across the board. If you want to go to the next slide, please, Sachin. We decided to break it down into national schemes and also the three boroughs. So if we look at the starting off on the left-hand side with the national, we've got QOF, QOF QI, so quality improvement, enhanced services, network contracted DES, network contracted enhanced services, and then investment and impact fund. So starting off with QOF at the top. So when it comes to QOF, we've got a major focus this year on influenza and vaccinations. They've decided to income protect 310 points. So the normal is about 587 points, and they've income protected 310 due to COVID having restrictions on primary care. So as I said, there's a new large focus on influenza and restarting and making sure people are getting their cervical cancer screening as well. There's also a little bit there on prescribing and medication reviews. Again, another important target, which is not income protected. When it comes to the second domain of QOF, which is QI, we're mainly made up of early cancer diagnosis and learning disabilities. I'll go on to more into what each target involves in terms of what we need to deliver and to meet these targets. Next is enhanced services. This is a paid per service scheme, which just looks at anything beyond the normal scope of primary care, including vaccinations, meningococcal, whooping cough, that kind of general thing. So no targets attached to this this specification, but as I said, paid by service. Next is network contracted DES. This is at a PCN level, covering a wide variety of certifications. The main two to focus on when it comes to GP practices is early cancer diagnosis and structured medication reviews. As part of the network contracted DES, you also have the investment and impact fund. This is made up of two domains. One which is prevention, what is it again? It's prevention and medication safety, and then also influenza, and there's another one. Sorry, I completely forgotten what it is. Oh, and tackling inequalities, which is looking at learning disabilities and making sure the reviews start again after COVID. These ones are, as I said, at PCN level, but they're measured at a practice. So your practice needs to meet the targets set, and then it contributes to the overall PCN average. Moving on to the boroughs, so you've got Lambeth, Lewisham and Southwark. Lambeth is lucky and has two schemes. It's got the PMS scheme and a Lambeth Primary Care Improvement Scheme. As you can see on the slides there, just breaking down which each one involves. Oh, apologies. I've just lost my slide. So as we step through it, so on PMS, we've got diabetes, prevention and care, influenza vaccinations, you'll see that's a trend across most of the schemes, bowel cancer screening, long-term care condition, post-operative care, what's that one? HIV screening and pulse rhythm checks. In Lambeth Primary Care Improvement Scheme, we've got prescribing and medication reviews, child IMS, SMI health checks, referral management, and multidisciplinary team working as well. In Lewisham, we've only got the one scheme, comprising of about 10 to 12 service certifications, as you can see and go through each category there. And then Southwark, you've got your PMS premium and your population health management. The main takeaway from all of this is that targets have kind of been removed from the borough levels, but it's still very, very important. We constantly work towards meeting each certification as we can. Moving on to the next slide. Here's a summary of where the overlap is. As you can see, the massive overlap in the prescribing medication reviews and in influenza. Child IMS appears in each borough at least once. And the same can be said towards diabetes prevention and MTD working. So the main takeaway from this slide is just that there's a lot of overlap. So not every single certification is unique. And as you can see, if we meet some targets, we're going to hit also national targets and at borough level. Now, when it comes to the types of certifications, we've got quantitative targets and we've got qualitative targets. So quantitative targets, and this means that a certification is asking the practice to conduct either reviews, tests, or tasks, which are then measured against the target or without a target. Now, the ones without a target are normally subject to monthly audits from the CCG, and the ones that have percentage targets are normally measured at the end of the financial year, so that's the 31st of March. For example, we have a QOF CS005, which requires 80% of women eligible for screening 25 to 49 within the last three years and 6 months. Another example of one that hasn't got a target is in Lambeth PMS, which is a cardiovascular pulse rhythm check. So it's just trying to try and bounce back from COVID and make sure anyone over 65 has had their pulse rhythm check. Now, when it comes to meeting quantitative targets, how are we going to do this? So these practices are going to be met by reception and clinical teams working hard together, working through a recall list, which is going to be provided by central management and distributed as soon as possible. We're building these dashboards as we speak. It's a lot of hard work going into it, and hopefully it helps you really smash the targets where we can. Now, on the other side, we've got qualitative targets. Now, these don't have any quantitative measurable targets attached to it. However, what it's asking you to do is to complete action plans, self-declarations, and peer reviews. So the amount of work specified can vary a lot, as it says, but there's a lot of careful consideration going into each one of our peer reviews, each one of our action plans as well. So although there's no measurable targets to be met, you're hopefully going to see the improvement as a practice across the board. So examples of this include, so in QOF, you've got a QI for showing continuous improvement in both your early cancer diagnosis and the way that you treat patients with learning disabilities. And then in Southwark, you've got a PMS, which is looking at how the practice plans to provide vaccinations for staff. And that's going to be measured via an action plan at the end of the year, I believe, or coming up at the end of January. So as it said there, how is this going to be achieved? So these specifications have been consolidated together, and we're studying action them appropriately, essentially by the data team and by lead GPs at each practice. These may lead to some changes in the SOPs, but lead GPs will work with you to make sure everyone knows what is going on and what is required. And here you can see a breakdown of how those different types of targets, so your quantitative targets and your qualitative targets, break down into each scheme. So as I said, QOF, you've got heavy quantitative target base. With your QI, you've got predominantly qualitative peer reviews. Again, as we go across to the boroughs, we can see the PMS and the LPCIS are mainly split in between the two. As I said, largely non-target based in Lambeth. Same can be said for Lewisham, mixed between quantitative and qualitative, largely non-target based, but I think there are a few that do require us to hit some. And then Southwark, which are taking a more targeted approach with a PMS and a non-targeted approach quantitative with a PHM. Very brief summary of everything that's going on with the KPIs in 2020-2021. There's a much more in-depth, comprehensive presentation which I presented earlier this week to lead GPs. If anyone wants to take a look for it, they're more than welcome to. It goes into real depth into each one of the specifications. I'll now hand back over to Sachin, who will provide a summary and move on with the town hall.
Perfect. Thank you, Greg. Hopefully you guys can see me. Yes, great. That's really, really helpful. So yeah, there's a lot of work has gone into trying to understand those schemes, trying to summarize those schemes. Like Greg said, there's another whole presentation which basically takes, because obviously these specification documents can be very heavy, let's say, and we've taken those documents and tried to summarize them kind of on single slides so you can sort of see what is required if you're interested. But the key thing I think to think about is just being ready for those quantitative targets, whether it's smears, whether it's flus, whether it's pulse rhythm checks, whatever it is, like we do every year. There is going to need to be some call recall, and we're going to need to be ready for that. Both reception teams and clinical teams need to be ready for that. Unfortunately, it's all, again, we always want to do this earlier in the year, but because of COVID this year, a lot of the specifications have been quite slow to release, and so we're probably later in the year than we want to be. But as Greg covered, I think a lot of these targets have actually been removed, so they're not going to be as stringent about it, which is good. But we still really do need to call those patients in and get the work done as much as we can do. So that is really it. I've got a slide here for questions, but I'm also sort of looking at Q&A and I don't see anything in there. Maybe if people have got questions, they can kind of post them as we go along, and we can. There are more question slides further down the deck. Great. Okay, so that's targets and KPIs. I'm really hoping the drilling sound isn't too bad behind me. It's very loud for me, but hopefully you guys hear what I'm saying. We're going to cover flu and COVID next, if that's okay. So I'm going to jump straight into flu. So again, very much, thank you guys for all your help so far. I think we're doing very well overall. We're at 45% achievement group wide, and the maximum progress there, the cohort where we're really doing well, is the over 65s. I think the two key messages here are that there has been a drop off in bookings. We were sort of anticipating this, so that obviously just kind of recalling back to the plan is really to do with it's kind of two parts. The first part is really, let's send texts out, let's open online bookings, let's get as many patients to book in as they can. And I think that worked really well. And we had lots of patients proactively phoning us up to book. We had lots of patients booking in online. I think at one point it was something like 25% of our flu appointments were online bookings, which is really great. But now we're into that second phase where we really need to buckle down and start doing some of those recalls. I think a lot of the patients who have wanted to book in have done so, and so now it's really for us to be calling the kind of remainder, that remaining, call it 50%, who kind of aren't maybe ambivalent about flu vaccine, or maybe they don't want one, but we need to phone them up and we need to understand whether or not they're having one, try and convince them to get one if they're not keen, and then make sure, most important of all, is make sure that we're coding it. If we don't code it, we don't hit the targets. You may have phoned the patient, had a nice half-hour chat with them, but it doesn't mean anything if it's not on EMIS, unfortunately. So that's really important. And I think one of the other points I wanted to make here as well is, I know that there are a lot of free flu slots at the moment because the bookings just aren't there. It's just becoming difficult to book patients in. I think what would be really great is if some of the clinicians who have got those free slots, you've got maybe half an hour in your book that's allotted for flu, if you can pick up that recall spreadsheet and ask your reception team if you're unsure how to access it and what to do with it. But if you can pick up that spreadsheet and just make 3 or 4 calls during that session when you're free, they shouldn't take more than five minutes each, really. It's just helpful, and it just start to get the momentum going in terms of booking those patients in. One thing I will say is that, kind of crunching the numbers, if we can do 5 per day per receptionist, so if each receptionist can kind of commit to putting aside 20 minutes, half an hour to call patients and to recall patients, literally 5 per day, it's not a huge target, then that will get us to our targets, without a doubt. Now, I know that doesn't sound like a lot, but up until this point, we've not been doing that. I know some have been doing more than others, but we really need a kind of consistent effort from everyone. So if we can get kind of clinicians really, if you're in those flus, if you're in a free flu slot, picking up the phone, and equally reception, I think if you guys are aiming for that 5 per day, that would be amazing, and I think that will help us really to hit our targets. The other 2 points on there, so in terms of our housebounds, they are mostly done now at Knights Hill, and we are in the final stages of planning at Penrose, so hopefully we'll get all of those housebounds ticked off in the next week or 2. And then in Lewisham, I think OHL are similarly in the middle of their scheme. I think they've said to us they're going to be finished hopefully by the end of this month. They seem to have quite a few left to do, but we'll see how they get on. They are definitely doing them, and they are definitely coding them. So hopefully you guys should be seeing that at Lewisham site. You should be seeing that in EMIS. If you're not seeing it, you've got a housebound patient who you think does need flu, hasn't been done, just let us know and we can make sure it's on their list, make sure that they know that they need to do it, etc. So that's your housebounds. And then the last point there is just on the 50 to 64 cohort. I actually had a message this morning about this, and I think it's an important point. So you probably have all seen, I'm not sure, but essentially the 50 to 64 cohort that was talked about for a while. So if you remember right back to when we talked about this at the first town hall, or possibly before that actually, the 50 to 64 cohort was going to be announced. So that's now happened. They've now announced it. It's going to be eligible from 1st of December. That's quite a big cohort. It's probably about, I think across our group, it's about 4,000 patients or so who fall into the 50 to 64 no other risk factor group. So it's if they're 50 to 64-year-olds who have got another risk factor, they'll fall into the at-risk group, and they will already have been part of our recall lists. But if they don't have any other risk factors, then they'll fall into that new 50 to 64 cohort, those 4,000 patients. Now, obviously, that's a lot. That's a big cohort of patients. I think we're basically very kind of early in discussions at the moment. So Karan, I know, has been ordering stock, so we're trying to get the stock in place to make sure that we can vaccinate those people, and then we are trying to work with our kind of local partners. So I know in Southwark, for instance, they're considering executing this at a PCN level. It's possible that in North Lewisham they may do something at a PCN level as well. Lewisham Alliance at the moment are thinking about, so that's LMC, are thinking about doing it at a practice level. And Lambeth, we're trying to figure out what their thoughts are as well. But I think we need to basically be prepped in terms of stock and in terms of being prepped for if we need to do recalls. The other thing I think to bear in mind is that we've got the COVID vaccination days, which I'm going to come back to in a second. But if we've got these two quite big, I mean, COVID vaccination days obviously is going to be very big, but if we've got this 50 to 64 cohort coming up, I think it's really, that just re-emphasizes that point around recall right now for the remainder of those cohorts. So yeah, I think so. Stacey's posted a very good question in the chat. Does the new cohort come under our target? The answer, honestly, is I'm not sure. The way in which these are assessed, so the ambition, I believe, still remains 75%, but that is very much an ambition. I'm not 100% sure where we're being assessed on them. We're going to try and see if we can find some more information about that. But I would probably say the main thing to do is focus, at least for the next week or so, on our current recall lists. And as far as we can, even after 1st December, we should really be prioritizing our kind of over 65s, under 65s at risk, 2 to 3 year olds. Those are our 3 big cohorts. And just make sure that we are recalling them, making sure they're coming in. So I'm going to just quickly, so hopefully you guys have all seen this. This is actually exactly the same set of data that I posted on Sunday to the general channel, so you'll hopefully have seen this dashboard already. But I just wanted to cover a couple of points here. So essentially, this is kind of site by site, just to recap that site by site. This is cohort by cohort. You can see, like I said, we're doing much better in our over 65s. We're at that kind of 60% mark. The under 65s need a bit more work, and similarly 2 to 3 and kind of your pregnant / other groups need a bit more work. But I think more interestingly is kind of at each site. So you can see we're all at a similar level, between 40 and 50%. And I think one of the things that's going to be really critical is basically looking at this dotted box. So this dotted box here, this dotted white box, is essentially the patients who we haven't been able to code yet. So if they have been coded as declined, they're going to appear in this grey box. If they've been done, they're going to appear in this dark red box. And if they've actually been booked in, they're going to be in this dark, this sort of lighter red box. But this white box here with the dotted line, these are the patients who either we haven't got through to them yet, or we have spoken to them, but maybe it's not been coded. I don't think that's necessarily what's happening a lot, but I think it's probably most likely, from what I've seen from the recall list, this is mainly the list of patients who we just haven't had a chance to phone yet. So you can see it varies. I think at Kingfisher there's really not that many left. The bigger sites obviously have got more, over 1,000, which sounds like a lot, but if you've got receptionists, maybe 3 or 4 receptionists a day doing 5 calls, that's 15 a day. You're going to get through this fairly quickly, and I think that's what we really need to focus on is getting through this chunk here in the dotted red box. The other thing I think it's probably other couple of things that are worth pointing out here. So these are just the actual flu jabs that have happened. So if you look here, you can kind of see, okay, so we all know that kind of starting in October, that's where we really started, and you've got some big peaks here. We really managed to keep it going quite well, about 100 a day for until mid-October. I think by the end of October, and I think for this month, it's sort of dropped. We're at probably more of a 50 a day average. In the last week, it's dropped even further. I think what worries me the most is really this forecast bit. So this is about kind of what's booked in for the next few days, and it's very, very small. So this is across the group. We've probably got a handful of patients booked in for flu jabs. So this kind of figure combined with this kind of figure indicates to me that we can be trying to call those patients up. I know that it's difficult. I know that doing the recalls is not the most fun thing to do, but you know, we need to remember that we're going to end up with another big cohort coming down the road in the next couple of weeks, and then there's the COVID vaccination des, which is coming probably end of December, early Jan. So we need to kind of be wary of that and really try and put a lot of effort into the recalls. Another thing I'll say is that if you look at this chart here, which a lot of you may not have seen or spent a lot of time thinking about in the past, but this is looking at a forecast. So if we forecast all the way to 31st of Jan, based on our current rate, if you assume that we're going to continue to see a little bit of drop off every day, just like 1% drop off every day, actually based on our current rate, we won't hit that 75%, which is very worrying. It's the first time it's dropped below that. I think that's because our rate in the last week has been quite low, but I'm pretty certain that we can do better. I know that we've had, you know, certainly for this period of time, we've had a very good sort of slow and steady jabbing. And I think if we continue at that sort of rate, then we'll do okay. The key thing is just going to be recalls. So the message here is just recall, recall, recall. And if there's any issues around the recall sheets, if you guys don't have access, if you're not sure how to use them, if you find issues with patients, or there's patients who you think should be on there but aren't, etc., any of that, please message me. It's really, really useful. It's useful information for us if in case there's a mistake in the actual recall list that we need to correct, or it's useful in terms of just making sure that everyone's on the same page. So please just literally drop me a Teams message, or send me an email, or even phone me. I don't mind. You can even come and find me. I really don't mind. But it's just a case of everyone engaging with those recall sheets. Okay, awesome. That's enough about recall, hopefully. You can only say that one word so many times. So I'm going to move on to COVID. A couple of these slides will be familiar, but then we're going to go into the COVID DES, which I think will hopefully be quite interesting. So this is a slide I think we've all seen before. This is as of Sunday, I think it is. So essentially we've updated that same chart. So this is, just to remind everyone, this is the confirmed cases for Lambert-Sollick Lewisham from 1st of March up until the latest data, which I think is about the 20th of November, so a few days ago. In itself, I think it's not the most sort of comforting chart. It kind of looks almost like there are more cases at the moment than there were back in March, although we'll come on to why that may not be the case in a second. I think one good thing to take away here is that obviously that peak here has sort of plateaued in all three boroughs and is actually starting to drop. So that's really good. So the kind of community levels of COVID seem to be dropping locally. So I've added a new slide here next, which I think is really interesting. So this slide here just looks at very similar data. So you can see the shape is very similar. You're kind of got that first peak and then a second peak. This is for the whole of London. So again, this is confirmed cases for London. The dark red line is just, the darker, thicker line is basically a trend line as opposed to actual individual data points. So you can see first peak, then over summer it's very quiet, and then sort of coming up to a second peak here. The thing that's really interesting, and the thing that I found really interesting when I was looking at this data and I wanted to share with everyone, is the deaths. So in March, April, we had a very unfortunate kind of high daily death rate. I think at the peak it was probably 200 or something like that. This is just in London. What's really interesting is if you come now towards this peak here in November, which looks bigger when you look at just the case numbers, what I find really interesting is the fact that actually the number of deaths has really not gone up. It's gone up a little bit, but we are not talking about nearly the same volume here. It's probably a factor of 10 lower than it was at its peak in the first wave. Now, there are probably a number of reasons for that. It's probably to do with volume of testing. So obviously in March, April, they didn't have the volumes of tests, so they weren't necessarily picking up the cases. Cases may actually have been kind of all the way up here, but difficult to know. I think the other thing that's probably quite interesting is just to do with treatment and how good we are at getting to treat COVID, and when it gets really bad, how good that is. There's some very interesting articles about that available online. I don't want to speculate on this too much. I'm not an epidemiological expert, but I think it just gives us a little bit of kind of comfort where I think this graph maybe looks a little bit scarier potentially. I think this one, does help to contextualize the severity of the current peak. Having said that, I think we don't want to be, while we don't want to be sort of overhyping the current peak, we also don't want to be underestimating it. So we're still very much along the same lines that we have been for the last, 9 months almost. Face coverings are compulsory for patients still. Infection control process at the door is still compulsory. Please let us know if patients aren't doing that. It's not allowed, and we will speak to them. Staff, obviously, for our team, we have to be socially distanced. We have to maintain optimal hand hygiene. And I think in terms of where you can't do that, you should be wearing a face mask. I know that people around Kingfisher have been much better at wearing face masks. Certainly in communal areas, I think people are getting better at it, so that's really good. It's just, it's safe for you, it's safe for everyone else around you, it just makes sense. The third point there, again, is about staff, is just minimizing face-to-face meetings. I know we're doing more Teams meetings, which is really good, but if you can't do it, then make sure we're distanced. And actually, really quite good news there at the bottom, which is that we haven't actually had any known cases, I believe, across the group in the last couple of weeks. So that's really good. And there is testing available. So if you do, if you are feeling any of the symptoms, which we know very well by now, then we should try and really be getting tested and isolating as soon as possible. So that's COVID, bit of context. And then I just wanted to quickly talk about the vaccination DES. So this is kind of just a very brief summary, and some of this it may or may not be accurate because it's all kind of up in the air at the moment. It's not final, but I just wanted to keep everyone updated just in case people haven't seen the stuff that's been going around in Pulse and on the news. So at the moment, basically, the DES is just preparatory, so we don't have a confirmed start date. The main thing that's happening at the moment is they are looking to designate sites. So obviously an important part of this upcoming vaccination program, if it happens, is going to be where do you actually vaccinate huge numbers of patients? How do you do this with potentially a different logistical challenge than normal flu, where you've got big packs, etc. So they're looking at designating sites, and I think that is what's happening at the moment. They're going to be publishing the actual final specification in late November, and it's only going to come into effect once the vaccinations become available. So we're a few steps away from this actually happening, even though that there's a lot of press discussion around it. I think it's worth bearing this in mind. Obviously, the other important point is that there isn't actually at the moment a confirmed authorized vaccine. There have been a lot of discussions around efficacy, and I think there are 2 or possibly 3 vaccines at the moment that have been kind of shown to be effective, which is really good and indicates that they may well be authorized for use. I know that the latest NHS webinars, so a lot of this data is from the latest webinar, which you can actually find the slides here when I publish this. They talk about the 2 candidate vaccines. So I think in the UK we're really considering 2, but they are both quite different in terms of their presentation and preparation. So one, for instance, is stored at low temperature. I think something like -80. I think one of them is stored at, although I don't think that means we will necessarily need -80 storage at site. It may be okay at a normal fridge temperature for a certain period of time. I think the other one potentially requires 2 doses. I think that might be the Oxford one. Again, this is just kind of preliminary information. We don't have the final information. There's no real point in putting a lot of thought or worry into any of this, because I think when we get the final information, that's when we'll pass it on, and that's when we start to really form a more concrete plan. The key thing to just remember is that really at the moment there isn't a confirmed vaccine. In terms of the logistics, it's still, again, speculative. A lot of the reason for that is because we don't have the answer to what the vaccine is going to look like. One of the key things they have been talking about is that it will likely be delivered in big packs, so almost 1,000 doses per pack. So one of the things they want to do is have sites where groups of practices, PCNs, potentially work together to deliver the vaccine, so that these packs aren't going to waste, because they may only have a shelf life of a week, for instance. So 1,000 obviously is a lot to do in a week for one practice. We're not 100% sure on cold chain yet. We're not 100% sure on handling. There may be preparation requirements. There may be dilution requirements. Again, it will depend on what is finally authorized and how it's finally produced. In terms of training and staffing, I actually haven't put staffing on here, but I think it's an important point. So in terms of staffing, the CCG is looking for sites where we're going to work together, but we will, like with hot hubs, I think our anticipation is that we will be providing staff to help run those. You know, we are the bulk of the primary care workforce. It's not like there are lots of, you know, nurses sitting out there waiting for work. So if you look across all the boroughs, you know, the majority of the nursing and the clinical workforce is going to be in general practice. So the likelihood is that we will be providing staff out. Again, we don't know how that'll look. We don't know the volumes. We don't know what the requirements are, but that's our speculation at the moment. In terms of training, I think that's one thing that NHS England have been relatively clear about. They're expecting that to be online. I believe they are preparing that training at the moment, and it will be different for different cohorts of staff. So clinical, non-clinical, for instance, will have different trainings. The last point on here that I just wanted to cover is cohort prioritization. I think it's probably as everyone probably would expect. There's actually a specific list. So again, if you look in those slides, you'll see a slide by the JCVI where they've actually listed out, I think, 10 cohorts and then kind of others. But the key message is it's going to start in the care home, so kind of the most vulnerable, then move on to your over 65s, then move on to your at-risk groups, and then your other ones. So those are your kind of, that's the rough order that the NHS England are currently telling us. Obviously, the exception to that is healthcare workers. So our teams, our frontline teams, are going to be in the first cohorts. That makes sense. I think if you're going to be vaccinating people, you need to be protected. You're putting yourself at risk, and clearly this is a sensible plan. So I think healthcare workers are in cohort 1 and 2 of 10. So no need to worry so much about that. But yes, that is really it. It's all quite speculative. I wouldn't necessarily expect anyone to really be spending too much time worrying about this at the moment, but it's just to kind of bear in mind, this is what's happening. These are the discussions that are happening at the moment. The timeline is very likely to be kind of end of next month, or probably more likely in January at this point. But it really does depend on how quickly they get the vaccine authorized, how quickly the supply chain in terms of supplying it to local sites is set up. Great. So I've got a question slide here again, but once again, there are no questions in the chat. So I'm going to just kind of maybe give it a second, but I think probably carry on, and we can come back to any questions as they come up. Okay. So now on to some of the more fun stuff. Christmas, Penrose Cup. I know Charlie is waiting in the wings to talk to us about Penrose Cup a little bit, but I'm going to quickly cover Christmas, and then I will introduce Penrose Cup, and then there's also a little surprise. So we'll come back to that. Starting with Christmas. Hooray! Some little Christmas trees. Unfortunately, I think you guys will have known this, and it's quite easy to predict. The chances of us having a big party this year are 0. It's just not possible. I think even if everyone was vaccinated by the 25th of December in the group, I think it's still very unlikely that the venues are going to be open and available. And I think it just doesn't really feel right for us to be having a big party when people are in lockdown and when there's risk to everyone else. But having said that, we really feel that it's important that there is some space and some time and some resource allocated for everyone to kind of get together as teams and kind of celebrate each other. I think it's been a really hard year. Everyone has worked really hard. It's been an unpredictable year. It's been a stressful year. And we, absolutely want there to be a bit of a space, a bit of a time for everyone to be able to kind of celebrate and just almost breathe a sigh of relief that the year is over. So we are proposing at the moment basically site-based parties, and I say parties, but this is obviously going to be completely social distance compliant, whatever the regulations are at the time of the party. I think we do have to make sure we're abiding by, but a get together at the party at the site. We're going to try and use the PLTs where possible. So there is, I know that there's an upcoming PLT in Southwark, there's an upcoming PLT in Lewisham, Lambeth, we're still waiting a date, but we are hoping for something at around the same time. So the idea would be is that the surgery is closed, and our calls are tripped over to CellDoc, and we can basically kind of loosen our belts for a second and sort of start eating some mince pies. So we're going to try and provide food, drinks, a Christmas kit. I'm not going to necessarily specify what's in that, but I'm sure you can imagine what might be in that. And we want to get the social committee involved. So you'll see on the next slide, and hopefully you've seen, I think Julie's post in Teams around the social committee. We've got some people already. I think we're still looking for someone from maybe LMC and Knights Hill to nominate someone. But that committee, I really want them to be involved in kind of helping us plan the activities and also helping kind of execute the parties on site. So that's kind of where we are. On top of that, we've got Christmas Jumper Day charity event, which is going to come in, I think, a couple of weeks, 11th December. So look forward to that. That will be exciting. It's not mandatory, but it is for charity, so it's really good, and it's a good bit of fun, and everyone can dress up. You don't have to have a Christmas jumper. I think you can just have whatever you've got, whether it's a little hat or some tinsel or whatever. You don't have to go out and buy a brand new Christmas jumper just for this. And then Christmas trees. I don't know if anyone's seen, but there's we've already got the Christmas tree delivery here this morning. So our resident Santa Bartek is going to be delivering very exciting Christmas trees to sites. I think probably today or tomorrow. Otherwise they're going to go bad in the back of his car. But yeah, that's coming, and I think you're also going to get decorations. So please, really have fun with that and get everyone involved and decorate the tree. I think it's good. Get everyone in the spirit and kind of make everyone feel really excited for the end of the year. So that's where we are with Christmas. If anyone has any thoughts, any ideas, absolutely please just message, talk to the person who's going to be in your social committee representative. They'll be able to kind of hopefully fold that into the wider plan. We're going to try and do something sort of consistent, but also obviously, if there's stuff that you want to do specifically at each site, then that's completely fine as well. So that's Christmas. Penrose Cup. I'm gonna give Charlie the microphone. Charlie, I'm gonna send you live. If you go off mute, and then you can tell us a little bit about your idea for a couple of minutes, if that's all right.
Sure. Hi there. So the idea of the Penrose Cup is to get all the. Oh, hang on. Am I live? Yes. So the idea of the Penrose Cup is to get all the practices together, and hopefully it's going to be something fun and a bit of a competition across different sites, and something to look forward to and something fun. And I actually made a video which has not actually gone viral until today. So I might ask Julie to see if she can send it around to people to have a look. So I'm just warning you, hopefully it's not too over, because I did try my very best, but it's a lot of fun making a video and see what you think, and it's explain everything. I'll pass it over back to Sachin.
Thank you, Charlie. I'm going to actually try and play the video now. If you just give me 1 second, I'm going to put this on full screen. I'm going to try this, see if it works. Send it live. Oh, okay. Let's have a go. This may not work, but we're gonna try it. Tell me if it works. Otherwise, we can just send the video around and people can see it. I think the volume may be low. I think it may not be coming through. I'm going to send you guys the video link. This was always quite ambitious, but hopefully you guys can see the video in your own time. As you can see, it's very exciting. So you just watch for that. I think Julie or I will post it in a second after the town hall. But yes, thank you for that, Charlie. Send myself live. Great. Sorry about that. It was very ambitious, but hopefully you'll get the link later. Ah, start again. Okay. Very good. Questions? No questions at the moment. I think I saw a question from just relating back to COVID was, is the COVID vaccination mandatory? I believe that it's unlikely to be mandatory. Very much like flu, it's not the sort of thing that they will make mandatory. It will, again, like flu, be highly recommended. And I think if you're going to be giving vaccinations to people, you know, it does make sense to have one because you're likely to expose yourself to the virus. And what you don't want to do, even for your own health, really, the key thing is to try and we really don't want to be passing it on to patients who are coming in for vaccines. So we don't know whether they're going to make it mandatory yet, but our understanding is that it's not at the moment. Yes, great. That is kind of the fun stuff. I think we're almost at an hour, so I'm going to very briefly fly through the next couple of bits. We might overrun by 5 minutes, but that's okay. So we're just going to do a little general update like we did last time, just to give everyone a little bit of an overview of what's happening, kind of other stuff that we haven't covered. We've got some exciting new starters. This page is thankfully less busy than it was last month. We've got Jo Harris, who's lovely new executive assistant in the team here. You guys will probably have maybe have heard from her. You'll definitely sort of see her or meet her in the coming days and weeks. We've got Harriet, who is a lovely new receptionist at. She's currently, I think, based at LMC, but she's actually going to be floating and working across the site and doing some coverage of holidays, etc. When needed. We got Pradya, who's our new clinical administrator at LMC, and we've got Olu, who is our a new GP trainee at Knights Hill. So welcome to all of those people. I know you guys will give them a warm welcome. In terms of leaver, again, thankfully this is a very sort of low volume of leavers. We've only got one. Anjali, unfortunately, the team at LMC obviously know her well. Is leaving us. I think it has left us actually last week. So you know, very, very sad about that, but hopefully kind of everyone is aware of the new starters and okay with that. Oh, hang on, where's my content gone? Oh, Charlie's trying to share his video. Hang on. See if it works, Charlie. Have a go. I think it's the same issue around sound. Yeah, I think it's still going to be tricky on the sound. I'll share them with everyone afterwards. That should be okay. Sorry, I'm going to take it back over now. Steel charge.
Not working.
I know. That's right.
Not working.
That's all right. I will. Oh, that's me on the big screen. Let me just share the slideshow. Great. Hope you guys can see the slides again. Okay, awesome. So those are your starters and leavers. We are still hiring. We're looking for more clinical administrators. I think we've got a few candidates we're interviewing this month, but if anyone knows anyone who maybe overseas qualified doctor or something similar, please let us know. We are always looking for clinical admin. That team is always really busy. And then in terms of for other people, we're looking for pharmacy dispensers. We are looking for a receptionist, and we are also looking for a GP. So again, if anyone has anyone, there is a referral program. I think the details of that have been circulated. If not, we'll get them circulated. So there is a small financial reward as well if you refer someone who ends up being with us for past their probation. So yes, that is the hiring. And then the last slide really is just kind of other stuff. We'll just shoot through them, and I'll also get Karan to talk you through a couple of the bits at the end that are particularly important that he's been working on. So we've talked about flu, we've talked about targets, we've talked about COVID, we've talked about COVID DES. Christmas obviously is a big thing. Lots of hiring happening. Penrose Cup actually isn't even on there. And then other stuff. We've got a change in the way that we screen candidates, so we're doing much more thorough screening of candidates. I think I mentioned it last time as something that was a work in progress. We've now kind of pulled the trigger on that, and we're spending a little bit of time now really trying to sort out, because we get huge numbers of applicants. You know, I'll give you an example. For our most recent reception job, we got over 1,000 candidates, I think, in just over a week. So huge volumes of people applying, partially I think because of COVID, because a lot of businesses I think are struggling, but also it's just I think it's a very kind of appealing and broad, it's got quite a broad appeal reception job. So it's really important for us to be able to kind of sort those candidates out and not have to read through 1,000 CVs, otherwise we might need a few more Helens. So we really have been trying to sort them out, and one of the ways we're doing that is through some testing. So hopefully that's kind of interesting. If anyone wants to have a go at the tests, they're actually quite fun. They're quite interesting. You just get an idea, and I can share your results with you if you want. It's completely free for us to use it for that. So just let me know. We're also using Bamboo more, so hopefully you guys have seen we're sending out COVID risk assessments. I think there's a couple of other things that Helen will send out in the next week or two, and hopefully it's just trying to speed up. If any of you guys have done some of the contract variations or anything where you needed to sign anything in the past, I think it's been a little bit manual, and now we're hopefully moving to a more virtual digital system, which will speed that up and also be kind of easier, so you can see all of that. We are, I say hired a rota coordinator, we haven't actually let them know, but we have been interviewing, we did I think in total 8 or 9 hours of interviews last week of rota coordinators, so really in depth, and hopefully we've got someone really good to step in. That will help smooth out some of these issues I know that people are having with books not being done, and potentially with holidays, etc. It'll take a little bit of time for that role to embed and that person to get involved, but hopefully if we've got the right person this time, which we feel we do, then that will solve a lot of those issues that I know have been coming up. I know the team are working really hard on it at the moment, but having someone dedicated to that is going to be a big difference. I know we've had, I think, one more 4-star party. I think Penrose maybe had one recently. That's quite exciting. Judy, I know, was around. So well done to Penrose, I think, for getting beyond the 4-star mark. I think the only one we're waiting on is LMC. So if you guys have any patients who you know like the service, have a mobile phone, basically is the only requirement. get them to leave a review, and it will kind of boost our average, and hopefully we can get us beyond 4 stars. Other stuff that's happening, so some of you guys may be aware, some may not. We're starting to have more kind of planning meetings, so trying to really not only focus, obviously we focus on a lot of the day-to-day firefighting work and kind of other stuff that needs to happen, but actually planning out kind of on a 12, 24, maybe even longer horizon, what are our priorities, what are the things we want to work on, whether it's to do with HR, whether it's to do with operations, whether it's to do with premises. There's a whole bunch of different stuff, and I know that there are lots of things happening and lots of things could be better. So this is really just a way of prioritizing those and working on them kind of slowly but steadily. So hopefully you'll see, you won't necessarily see the specific minutes of that, they're quite long and quite detailed, but hopefully everyone will kind of start to see some of the efforts from that filter down. So that's exciting. There's a list validation exercise that's happening at Penrose. It's quite a bit of a grind, and I think it may come to other sites. This is just to do with PCSE checking our list, and you know, there are maybe some patients who are stuck in the ether who have deregistered but not re-registered, etc. So just watch out for that. If you do see an email come through from PCSE, please forward it to myself or Naveen, and we can try and pick that up ASAP. I know Dad and the team here have been moving towards a group Amazon account, so trying to basically set up ordering for sites. So your reception leads will be set up with an Amazon account if they don't already have one, and it will hopefully just streamline some of the purchasing. It seems silly for us to have to approve orders for pens and paper. You know, you guys, we trust you guys with that sort of stuff. So you'll hopefully see that coming soon. Workstation assessments is again quite an exciting thing that Dad's been working on. I think we've got a new kind of 2-part system. So there'll be a form coming from Joe, who I mentioned has just joined us, which is talking about the best practices around your desk and your display screen equipment and your keyboard and mouse, etc. So please watch out for that. That will actually come through on Bamboo. So kind of tying into this point here. And then after that, I think if you need more assessments, we're also doing something called Work Happy, which is like a virtual assessment. It's really good. We've done a few of them. I've tried it. It's really actually quite interesting, and it teaches you a lot. And it hopefully, you know, if you can do them and really spend just a little bit of time, I think they only take sort of half an hour or less, then we you know, it will potentially save you a lot of long-term chronic problems, you know, back issues, etc. It's really important to get your workstation set up correctly. Karan, if you're with us, you could maybe talk us through the next 4 or 5. We've got Karan.
Yes.
Do you want to talk us through the EMIS tasks and just briefly kind of overview?
So we've done some work on EMIS tasks across all sites. That we found that there were lots of tasks pending, mainly allocated to those who've left the organization, and that led us to rethink the whole process, and we redesigned the process. Leads have been informed, they've been retrained, and I'm sure the training's been passed to other team members. Basically, the changes were that how we send the task should be sent to teams rather than individuals. And the leads were dealing with the pending tasks from ex-employees. Dr. Hawkswell has looked at all the tasks from the locums, and leads are also now involved in monitoring of the tasks on a weekly basis. We were doing some research on Document. I know many doctors have used it in their past jobs, but Document 10 still has its own limitations. To name a couple of important ones, which I found were really significant, is it still doesn't link with GP to GP. So if a patient leaves us, their document letters don't get transferred to the new practice digitally, which means we have to print everything from document, and that obviously creates more work for reception. And document letters are also not visible online if a patient is viewing their records through patient access. So these were the 2 main issues. And referring back to the EMIS tasks issue that we we tried to resolve last week. Having document 10 as another system for managing tasks is probably going to cause more confusion in the team. We already have this issue in the organization of having number of systems. So we're trying to not embark on document this year. It's probably going to be summer next year when they've addressed all the limitations. EMIS training is something that's come up recently. We've obviously got a lot of new staff members joining in the last 6 months, and the training is being reviewed and improved. A lot of the team members that we now have are from secondary care. They have very little experience of EMIS, so we are setting up monthly EMIS training with the CCG and LCSU team members. There's one session happening next Wednesday, which I'll share after this session. It's a MS Teams session. Anyone can join in for as long as they want. Next week, we're going to talk about different consultation modes, workflow, and read codes and templates. But you can ask more questions in the template, and that'll help us actually design the future training sessions. eConsults, there's a big development this week. eConsults will now start coming directly. This is only obviously applicable to Nightcell and Penrose. eConsults will start coming directly into EMIS, like we receive NHS 111 letters. It's been switched on. Clinical admin team is aware, and we're writing a little protocol which will be circulated tomorrow on how we code them and how we pass on to the relevant team members. There were a number of significant events recently logged, and most of them were linking to missing emails or unread emails. There's a delay in dealing with patient letters. So that made us rethink how we manage our generic inbox, and Bex has been working on redesigning the inbox structure. We have new folder structure, which will make a lot of the work coming to the clinical admin team. So all the discharge letters coming from the hospital will automatically divert into admin folder, so which obviously helps reception. They won't need to sift through all the emails and pass on the relevant ones to admin. Office 365 rollout is happening at borough level at all 3 boroughs. CCGs have been working hard to procure the Office 365 license, but it's unlikely we'll get the full functionality this year. We have got Office 2016 at all sites, and it does come with Microsoft Teams automatically installed on your desktop. So if you don't have Microsoft Teams automatically installed on your desktop, please can you let us know. Holidays carry forward, so we've obviously, because of COVID and lockdown, many staff members were not able to travel. Most of us were not able to travel and take time off. Everyone's been working very hard without much break. So there were a few, around 9 or 10 staff members across the group who have more than 1 week of leave remaining, and I've written to them asking them to have a discussion if they can take some time off before 31st of December. For those who have 1 week or less remaining, we will be carrying that forward to next year. Christmas leave for this year, mostly approved. There are a couple of requests pending, but they are in the pipeline to be approved by end of this week. Reception leads are working on reception rota. There is a good chance that we will have to close the branch sites, Maddoxway and Surrey Docks, due to lack of cover, but the closure will only be temporary and only for a couple of days. Other than that, day-to-day work carries on. Sachin?
Perfect, thank you, Karan. Yeah, I think that's really helpful, and some really interesting stuff there. I know some of it's quite nitty-gritty, but it's important. These are kind of the operating cogs within the practice, and if they're not right, then they can cause problems. So hopefully you'll see some of the fruits of that labour soon, if you haven't already. The other thing is that I just wanted to add here, I just find this a really interesting statistic. I want to try and in future publish more of these statistics, but we've seen, this is just the work that we've been talking about, that kind of is happening at head office, and there is so much stuff that happens at the sites. 10,000 appointments have been had in literally 20 days. That's not even 20 working days, that's just 20 calendar days. So clearly there is far more work that's happening, but it's just this is just a small slice of it. That's it. Next town hall is really going to be a little bit earlier. It's going to be December 18th. Just try and stay clear of the season, the holiday season, people being off, and then we'll go back into a bit more of a normal end of the month, 26th, 25th, thereafter. So yes, I'm going to try and get these calendar invites in earlier with the help of Joe, and yeah, we hope to see you soon. I don't think there are any more questions in the chat. So we will call it a day. Thank you to everyone who's tuned in, and I will post the slides and the link probably later tonight into the Town Hall channel. Thank you, guys.
Thank you. Thanks.